Hello everyone. After talks on different topics in neurosurgery, we will have a short discussion on the previous year questions that we have found in the exams. At what blood supply does brain ischemia occur? 20, 55, 45, 90? The answer is 20. Remember, normal cerebral blood flow is 50 to 60 ml per 100 gram of brain. When the cerebral blood flow drops below 20 per 100 gram per minute, the brain tissue receives insufficient oxygen and glucose, leading to ischemia and neurological dysfunction. Below 10, there is irreversible neuronal damage and infarction. And brain ischemia present with symptoms like confusion, weakness or stroke, or depending upon the duration of the region of the brain involved. Hypoperfusion, embolism, hypotension are all different causes of reduced blood flow leading to infarction. Sudden onset of headache and nuchal rigidity in a woman without history of hypertension. Remember, nuchal rigidity is always a hallmark of subarachnoid hemorrhage. Why? Subarachnoid hemorrhage will lead to irritation of the meninges leading to nuchal rigidity. Nuchal rigidity is when there is neck flexion, there is restriction of the neck flexion, or there is something called as Budinski sign when there is neck flexion causes hip flexion, so as to decrease the meningeal irritation from the flexion of the neck in case when there is subarachnoid hemorrhage and the meninges are already inflamed. It is associated with sudden severe thunderclap headache, that is subarachnoid hemorrhage, that is non-traumatic subarachnoid hemorrhage or an unusual subarachnoid hemorrhage. It is described as the worst headache of patient's life and accompanied by nuchal rigidity due to irritation of the meninges. Mixed and combined patterns of post-traumatic intracranial hemorrhages and contusions will have different presentations, though nuchal rigidity should be a hallmark of subarachnoid hemorrhage. EDH follows a trauma generally, and non-traumatic EDH is very rare and less commonly associated with nuchal rigidity. And intracranial cerebral hemorrhage will usually occurs in hypertensive hemorrhages and very more likely to cause neurological deficits rather than nuchal rigidity. And intraventricular hemorrhage may cause more global deficits and less likely to cause nuchal rigidity. A child presents with brain tumor diagnosed as pilocytic astrocytoma on histopathological examination. Which genetic mutation should be tested for? Remember, 3 or 4 of this are genetic markers for brain tumors. Remember, all 4 of this are markers for brain tumors, though they are specific for different kinds of brain tumor. For example, TERT mutation occurs in high grade gliomas such as more definitely in glioblastoma multiforme or grade 4 gliomas. IDH1 generally occurs in grade 2 or 3 gliomas, though it can occur in high grade, generally occur in high grade gliomas. And ATRX gene can occur in generally any gliomas, whether it's astrocytoma or oligodendroglioma, it's generally non-specific. Here the question was, child presents with pilocytic astrocytoma. Pilocytic astrocytoma is generally a low grade glioma, and hence more specific answer should be a BRAF gene. Pilocytic astrocytoma are low grade gliomas in children divided by MPK pathway, though as you can see BRAF K1 fusion occurs and less likely, and BRAF V600E mutation which may guide targeted therapy. ATRX mutations are also associated with tumors but are non-specific for children. Remember, this is a general tabulation of the different gliomas and different IDH mutations and ATRX and 1p19q deletions. The TERT mutation, as you say, had occurred in high grade gliomas, ATRX mutation liquid to astrocytomas, and IDH mutations occur due to in adults. This a small summary of genetics in brain tumors, because since 2016 genetic markers have been a key part in molecular markers in brain tumors, have been a key factor in deciding treatment of brain tumors. In late 2000s, researchers discovered IDH1 gene mutation in some glioma patients linked to better survival. IDH1 linked to better survival rates. The codeletion of chromosome at 1p19q was found to be associated with better outcomes and response to specific chemotherapy. Oligodendrogliomas should have both IDH mutation and 1p19q codeletion, and it is called oligodendroglioma. Nowadays, it is called oligodendroglioma. And after 2016, if the tumor had both IDH and 1p19q IDH mutation and a 1p19q codeletion, while astrocytoma have IDH mutation but 1p19q was intact. IDH mutations are both an early event in tumor development and a factor in mitigating severity. Mutate IDH enzymes overproduce 2-hydroxyglutarate, altering DNA epigenetic markers. And about 40% of people with oligodendroglioma or astrocytoma with IDH mutation carry a single nucleotide polymorphism in the 8q24 region of the genome. Another SNP in the 11q23 region increases the risk of IDH mutation brain cancer and hence a poor prognosis. And 5 to 8% of gliomas are familial, occurring in people with at least one close biological relative who has had a glioma. In 2014, the first gene associated with familial glioma, that is POT1, was identified, and recently a CRISPR Cas9 mouse models have used to evaluate the effects of various mutations on glioma management, leading to opening up of what can be called as a personalized genetic therapy for brain tumors. Thank you very much. We have discussed a few questions that were asked in the previous exams, and in this videos we have learnt some basics of the neurosurgical topics, and hence I encourage the students to do more, to answer more questions, to see more questions and develop their analytical techniques. Thank you very much and all the best for your further endeavors. Thank you very much.